Hello and welcome to the YouTube channel. In this video, we're going to explore the management of chronic pain with a particular focus on the role of non-medical prescribers. My name is Camille, a clinical education company that delivers CPD accredited education for healthcare practitioners across the UK. Chronic pain is one of the biggest challenges in the UK at the moment. Around 28 million people live with some form of chronic pain, and that's roughly 1 in 3 adults. Around 1 in 10 have pain so severe that it impacts their ability to carry out work or their daily activities. The effects are wide-ranging. For example, it means persistent discomfort, disability, and disruption in their lives. And for the wider society, it means billions of pounds lost in productivity and healthcare costs. NHS England reports that musculoskeletal pain alone is responsible for 30 million working days lost every year. And then there's the mental health burden. Patients with long-term pain are more likely to suffer depression, anxiety, sleep disturbance, and social isolation. This can create a vicious cycle where pain worsens mental health, and poor mental health makes the experience of pain even harder to live with. So as prescribers and clinicians, understanding chronic pain is not just about choosing medications, but also supporting our patients holistically, addressing their physical, psychological, and social needs. So, understanding pain. Where do we actually begin? Pain begins with nociceptors, the specialized nerve endings that respond to stimuli such as pressure, temperature, or chemical signals from tissue damage. These nociceptors send electrical impulses along the peripheral nerves into the spinal cord. These signals are then processed, amplified, or dampened, and then sent upward towards the brain via the ascending pathways like the spinothalamic tract. When the brain receives this input, it integrates it with the context, emotions, past experience, and the current environment. And that's why pain is not just a physical sensation, but also a subjective experience. And this is where things get really interesting. In chronic pain, the system becomes dysregulated. Normally, when an injury heals, pain signals will reduce and eventually stop. But in chronic pain, the nervous system undergoes changes, a process we call central sensitization. In central sensitization, the spinal cord and brain become hyper-excitable. Pain signals are amplified, and even normal stimuli like mild touch or mild movement can be perceived as painful. Essentially, the pain pathway becomes a kind of memory. There are also changes in descending inhibitory pathways. Normally, the brain can dampen pain signals traveling from the spinal cord, but in chronic pain, this inhibitory system may weaken, allowing more pain messages through. This is why chronic pain is considered a disease in its own right, and not just a prolongation of acute pain. The original injury may have healed, but the nervous system continues to generate pain. So how do you define the pain? The most widely used definition is pain that persists or recurs for longer than 3 months beyond the usual course of healing and is not explained by ongoing tissue damage alone. This definition is useful because it emphasizes 2 points. Firstly, the time element. We generally use the 12-week mark as a threshold. And secondly, chronic pain is not just about structural damage. You can have chronic pain without obvious pathology on a scan, and this can be difficult for patients to accept and also challenging for clinicians because we're always on the look for something to fix. So how do you manage chronic pain? There are some general principles and challenges, and we'll talk about them. Imagine a patient with chronic low back pain. They've had this pain for years, and despite multiple interventions and investigations, no significant structural abnormality has been found. The pain limits their mobility, their sleep, and their ability to work. They've tried several medications, however, these have been with a mixed result. So how do we approach this? Firstly, we need to set expectations. The goal is usually not to eliminate the pain completely. That is rarely achievable. Instead, the aim is to improve the function and the quality of life for this patient. For example, we can help them return to work, exercise moderately, or carry out their daily activities without overwhelming discomfort. Second, we need to recognize the role of medication is that it's only one part of the plan. Analgesia has a role, but it should be combined with physical therapies, psychological support, and lifestyle strategies. And third, we need to remember that the way we communicate is part of treatment. If we label somebody simply as chronic pain patient without offering a plan, it can make them seem we are dismissing them. Instead, we should frame it as a more manageable condition, which can be more empowering for the patient. Take this study. This systematic review, which is a large study, pooled data from 33 studies involving over 3,000 asymptomatic individuals. All these patients went through spinal imaging, mainly MRI scans, across the different age groups. The aim of the study was to assess how common degenerative changes are in people without back pain. The results did show that features such as disc degeneration, disc bulges, disc height loss, and signal changes were extremely common even in younger adults. For example, by the age of 30, about 52% of patients had already evidence on the MRIs of disc degeneration, 40% of them had disc bulges, and 34% had disc height loss. The key message from this study is that spinal degeneration is often a normal part of aging and not necessarily linked to symptoms. As we're in the mind frame of trying to explain a patient's pain, we end up using the words such as degenerative spine, which could be normal for the patient. This risks labeling the patient and defining them based on their X-ray findings alone. Now let's talk specifically about medications. Non-opioid analgesics such as paracetamol and NSAIDs can have a role, particularly in musculoskeletal pain, although long-term safety considerations need to be taken into account. For neuropathic pain, drugs such as amitriptyline, duloxetine, gabapentin, or pregabalin may be indicated. These medications target the nerve-related mechanisms rather than the pain itself. Opioids, however, are much more problematic. While they may be useful in acute pain or cancer-related pain, in chronic non-cancer pain, they are rarely effective long-term and can lead to dependence, tolerance, and other side effects. As prescribers, you need to be cautious, use the lowest possible dose, and always review the ongoing need. A good rule of thumb to follow is to avoid the prescribing trap. Don't just escalate doses because the patient is still in pain. Step back and consider whether the medication is actually improving their quality of life or whether it's time to try an alternative approach. Dealing with the psychological impact. Living with chronic pain is often mentally draining. Patients feel that they're not being believed or listened to and nothing can be done. This can lead to them being low in mood, expressing frustration and even anger in your consultation. Our role is to acknowledge and validate their experience simply by saying things such as, "I can see how much this is affecting your life," can make the patients feel more understood. Psychological support is crucial. Approaches like cognitive behavioral therapy and acceptance and commitment therapy have evidence in helping patients change their relationship with pain, focusing less on eliminating pain and more on living well despite it. For example, with our patient with chronic back pain, instead of aiming for zero pain, the shared goal might be to walk to the local shops or to sleep the night without being woken by discomfort. Small functional goals are motivating and realistic. So here are some consultation tips for non-medical prescribers in consultations. Ask your patient about the impact, not just the intensity of the pain. So instead of just asking for a pain store, also ask, what does the pain stop you from doing? This shifts the focus to function. Utilize open-ended questions. Encourage patients to describe how pain affects their role as a parent, partner, or worker. This helps you understand their burden. Explore mood and sleep. These are often overlooked and can make a huge difference to an overall quality of life. Avoid medical jargon. Explaining pain in simple terms like the nervous system being oversensitive can help patients understand why the pain persists even when scans are normal. Work collaboratively. Involve the patient in shared decision making, which improves adherence with treatment and also empowers the patient. Remember, there are support services available so patients are not alone in managing their chronic pain. NHS pain clinics provide multidisciplinary care involving physiotherapists, psychologists, nurses, and pain specialists. Referring patients here can give them access to a team-based approach. Pain Concern is a UK charity offering a helpline, education resources, and patient support. Versus Arthritis provides information and networks for people with musculoskeletal pain. NHS Live Well has self-help management resources, including advice on exercise, sleep hygiene, and stress management. And some local commissioning groups have also got their individualized pain management programs. Signposting patients to these services reassures them they're not alone and their pain can be managed in multiple ways. Remember, chronic pain is incredibly common in the UK, affecting millions of people and costing the healthcare system and wider economy dearly. It is defined as pain lasting longer than 12 weeks and reflects changes in how the nervous system processes pain. For non-medical prescribers, managing chronic pain is about balancing medications with self management strategies, addressing the psychological impact, and using strong consultation skills to validate patient and set realistic goals. It's about partnership, working with your patients, signposting them to services, and using medications wisely. So thank you very much for watching. If you enjoyed the video, please like, comment, and subscribe, and we'll see you on the next Pareto education video with more clinical tips.